Good morning, good afternoon, or good evening, wherever you are. It is really my pleasure and privilege. My name is Abdurrahman Nimeri. I'm the chairman of the ISO Communication Committee. And today we have our journal club in its newest format as a webinar. It is really my pleasure and privilege to have Professor Frits Berends from the Netherlands to discuss their latest randomized controlled trial, the Elegance Trial. This is a trial that looks at the limb length of Roux-en-Y gastric bypass. We really look forward to an excellent presentation. Before we start, I just wanted to take care of some housekeeping issues. Please make sure you write any questions you have, and we'll get to them once the presentation is finished. In addition, we have prepared four poll questions to get your opinion about topics as it relates to this study. And we will do the first poll before Fritz starts. Then we'll do the second poll as soon as he finishes his presentation. And then as we go, we'll do the last two polls. So without further ado, I'm going to start first by getting the first poll question out. Please answer this question. I'm going to read up the question loud as well. Do you prefer sleeve gastrectomy or Roux-en-Y gastric bypass as an option for your patients? And the options are A, mostly sleeve gastrectomy, B, mostly Roux-en-Y gastric bypass, or C, both. Now, once we do this first poll, then we will have Fritz get started. So I'm going to give you guys a few minutes to answer. And as you answer the question, I'm just going to go over a few things. If you look at your platform in the bottom, there's something called Handouts. And in the handouts, there are two handouts. One of them is the article itself. Springer has been generous enough to keep it as open access for the last 4 weeks. And also, you'll find a GIF file that contains the visual abstract of this article. And then above that, you'll find the area of questions where you can actually type in your questions. So I'm going to close the poll now, and we will show you the poll results as we finish the presentation. So I think without further ado, I would like to ask Professor Frits Berends to start his presentation and tell us about his Elegance Trial. The title of the trial is Longer Biliopancreatic Limb in Roux-en-Y Gastric Bypass Improves Weight Loss in the First Years After Surgery, Results of a Randomized Controlled Trial, the Elegance Trial. Fritz, please go ahead.
Thank you, Abdurrahman. It's a real pleasure and honor to be here. Manuela, if you would start the presentation, please. So there we go. So I realize this is the first time that we're doing this journal club in this new format. So I hope I won't disappoint you in telling you our story. As said, today we're talking about gastric bypass surgery and whether or not a longer BP limb can add to weight loss. And as a spoiler alert, I'll tell you in advance, I think it can. So you must realize that when we started this trial, it was maybe 8 or 9 years ago, around 2011. And at the time, the general concept about how bariatric surgery works was very much in terms of malabsorption and restriction. So a very mechanical approach to how the operations that we do work. But there was a change in thinking at the time towards a more metabolic mechanism, and several new terms were introduced at the time, as you can read here: bile acids, L cells, hindgut, gut-brain axis, and especially this hindgut concept was very appealing to us because it states that if you land food more distally in your small intestine, then that helps in achieving weight loss through several mechanisms. And I don't want to explain to you how all these mechanisms work here, but it's very interesting if you look at basic gastric bypass design and you start counting your limb lengths from transligament, then when you make your BP limb longer, then automatically the connecting part ends up as your GE anastomosis. And that's exactly what the hindgut theory says. If you make your BP limb longer, not only lands food more distally in your gut, but also bile acids land more distally at your JJ anastomosis. And the question arose if a longer BP limb could help through this hindgut theory in achieving more weight loss. It was always puzzling to us, to me, that this gastric bypass that we're doing nowadays is a very old design. And in the last 50 years, hardly anything changed about this basic gastric bypass design. And if you look at literature, it's very strange that there's so little research about, for example, pouch size. We tend to make very small pouches. Same goes for Roux limb length. There is some RCTs about that, showing that there's hardly any difference to be gained in weight loss terms. And there's hardly any research went into the length of the BP limb. If you look in literature, then there is to be found a few case reports and cohort studies that look at the BP limb. For example, this one from obesity surgery from the Icelandic group, and they show that if you make the BP limb longer, there's actually something to be gained. But there's not a lot of scientific evidence. So we were in need of good solid trials to prove that concept. And that's the reason that we designed our trial, our Elegance Trial, which started with inclusion in 2012. And we took as a standard group the bypass that we did at the time with a short BP limb of 75, which is not very short, but it's just what we did at the time. And we compared it to a far longer BP limb with limb length that were vice versa to the standard group. And you can easily see that in both groups, the portion of excluded small intestine was a little bit over 2 meters. Now, the design of the study was very standard. It was a straightforward RCT in a single center, and we calculated our sample size on a 10% excess weight difference in 2 years' time. And it left us with two groups of about 70 patients. Now, the surgeons obviously knew which operation they had to do, but the patients were blinded for the operation they received. Later on, we extended the follow-up period to 4 years, which is important to note for the final analysis. Now you see here that the patient characteristics in both groups were roughly the same, but we had some problems in randomizing in our long BP group because we had some crossovers. Patient that should have gotten a long BP limb, but finally didn't receive that treatment, but instead received 1 sleeve and 3 short BP gastric bypasses. And later on, that's important to know that for your analysis, that makes a difference because you could choose to do an intention to treat, but we chose instead a per protocol because after all, that was the treatment they actually received. Now going to results, this is the most important graph maybe of the whole presentation. Excess weight loss after a few years. You see that the graphs are going apart already after 6 months with a high point after 2 years. And there was a marked excess weight loss difference after 2 years of 85 against 73%. And 73% in the standard group is not so bad, but as you can easily recognize, the other one is better. And even after 4 years, there was still a significant excess weight loss difference. Now, we also measured total body weight loss, and unfortunately, although there was a significant difference after 2 years, that disappeared sort of after 4 years, which was a bit disappointing, to be honest, but probably has to do with the number of dropouts that we knew in our post-operative period. If you look with me and what happened after randomization, then you see that we as I explained already, lost a few patients in the beginning, and then from there on, we lost a few patients because one died, few got pregnant, and in the end, we ended up with a smaller group than we started off with. And because the total body weight difference wasn't that large, I think we ended up with a sort of a statistical type 2 error in sample size. Would you have chosen a larger group, then I'm pretty sure that there would have been a significant difference. I suspect this because we did a similar study that's going to be read in SWORD in a short while on secondary surgery, exactly the same design with a similar difference in total body weight loss. And there we didn't have so many dropouts and saw a significant difference. So a type 2 error is very likely that happened. Going on glycemic control, as you can see, about 30% of our patients had type 2 diabetes, a very good remission and partial remission percentage in both groups. So even in the short limb group, glycemic control is excellent. So not a big difference could be determined, but after all, this study was not powered on glycemic control, but on excess weight loss. Focusing on complications in the short term, you can see that we had one serious bleeding afterwards that finally led to a death in the short group, and we had one other death due to probably a thromboembolic event in the home situation, leading to a very unusually high mortality rate in this series. Fortunately, in our clinic that does more than 1,200 procedures a year, the mortality rate is 0.2%, which is far more acceptable. Hypertension and dyslipidemia, other comorbidity outcomes. Hypertension, as you expected, improved significantly, but there was no real difference between groups. Interestingly, there was a significant difference in dyslipidemia, and think about how that could come to be. You could suggest that there's a mechanism, because we already commented on bile acids that are maybe in a longer BP limb better resorbed, and there's a sort of inverse correlation between bile acids and plasma cholesterol and lipids. So a longer BP limb could possibly lead to lower lipage, which could be the explanation for this significant outcome after 4 years. Overall conclusions of this study, with a BP limb of 1.50 m, you do find a significant better excess weight loss. But as the study was not powered for the other outcomes, we saw marked improvement after this treatment, but no difference between groups. Should you have chosen a more, let's say, a longer BP limb, a longer BP limb compared to a shorter BP limb, then probably you would have seen some differences as well in the other outcomes. So that's something to look at in future studies. And during an early interview with Abdul Rahman, he asked me, why do we bother so much about gastric bypass surgery, where the majority of surgeons in the world nowadays are doing sleeve gastrectomy? Should you focus so much on gastric bypass? I don't want to get into the discussion of comparing procedures per se, because you easily land up into a sort of a scientific quicksand where everyone starts shouting why his operation is better. But what I do ask is, when you start comparing methods, such as in the SM-BOSS study, for example, that you should not be comparing a sleeve that is very well studied with a very old school gastric bypass model. So please look into a modern concept of a gastric bypass, and then you can do a fair comparison. Looking at the outcomes, metabolic outcomes of bariatric surgery, metabolic surgery, I still think that the gastric bypass concept holds the best cards compared to a sleeve. That's probably the reason that in the Netherlands 80% is still gastric bypass. My final comment on this, if you do gastric bypass surgery and if you want to go for the optimum result, then please rethink your strategy and consider a long limb gastric bypass. Thank you so much.
Thank you, Fritz. This is really an excellent presentation. And I have several questions for you, and I'm sure we will have questions from our audience. But first, I would like to actually see if we can get the results of the first poll that we did. Okay, so the people who took the poll, 60% said mostly Roux-en-Y gastric bypass, 20% said mostly sleeve, and 20% said both. 68% of the people who were present voted. Okay, so can we first do the second poll, and then we'll start some questions. Okay, so this is the second poll. When you perform Roux-en-Y gastric bypass, select one of the following. A, when would you perform it? Meaning never. B, in case of type 2 diabetes. C, in case of GERD. Or D, in case of weight regain after sleeve. Now, I do recognize you might want to choose more than one, but choose the most one that actually you feel is appropriate. So while people are answering the poll question, I would like to first ask Fritz, what do you currently do in terms of the biliopancreatic limb for your patients based on the two trials you've done? The one for primary Roux-en-Y gastric bypass, which you showed us, and the redo Elegance Trial, which you did for reoperative surgery. At your center now, what is the length of the biliopancreatic limb that you actually do today?
Yes, I understand it. Well, we do exactly what we did in the trials. I'm a very traditional and conservative guy, so before I change anything in my ways, or in our ways, I should say, then there has to be overwhelming evidence that I'm going to do something better. After having done these trials, we change our ways in the way that we now do a BP length of 150 centimeters, which was also the case in both trials that we did. And I can say that more than 50% of the Dutch surgeons now have adapted to that, let's say, longer BP limb technique. Now, I think that this is not the best bypass you can possibly do, because there's probably room to make your BP limb even longer. But before you embark on that voyage, there should be more evidence. Now, you're probably aware of the study that Niergaard published in 2014. They chose to do gastric bypass with a 60 centimeter Roux limb and a 2 meter BP limb, and they had even better weight loss results, about 80% excess weight loss, even after 5 years. So that's probably a direction you could think in, and that's something we're investigating right now, but it's maybe a bit too soon to make such radical steps already. So I'm very conservative once again. So we did what we investigated in the trial and what we think is good evidence for at the moment, but I don't exclude the possibility of going to a little bit longer limb in future.
So let me ask you a question about the Niergaard trial of 2 meters of biliopancreatic limb. If I recall correctly, they found that the incidence of nutritional deficiency was higher in the longer BP limb, yet your trial did not show that. Do you think, is it because a shorter BP limb of 150 is better, or is it because this is a type 2 error in your trial? What are your thoughts?
Now, I'm not sure. You know, the reports on deficiency is always very difficult, because the trial was not designed to look at vitamin deficiencies, and during follow-up, they're constantly corrected for deficiencies. But I do agree that if you make your BP limb longer, especially for iron and for calcium, the chances that you start developing deficiencies increases. So you must have some kind of regimen in place to cope with that. On the other hand, the weight loss is always a sort of a trade-off between having more deficiencies, on the other hand, have better weight loss, which will help your resolution of comorbidities as well. I think that if you have modern deficiency medication, such as is provided by Fit4Me, they have excellent vitamins prepared even for malabsorptive procedures. Then you could cope with the deficiency problem and add to your weight loss. So I think that the NearGuard group should be commended for their efforts. They have still they've done an excellent trial that's referred to too little. The only thing you can say from their trial is that in the one group they excluded a little over 2.5 meters of small intestine compared to a group of a little bit over 2 meters. So there was a sort of an exclusion of small intestine difference, and it's very hard to tell whether the extra weight loss was due to your extra malabsorptive component or your long BP limb component. That's the exact reason that we didn't choose a difference in totally excluded small intestine.
So I have a question about your trial design, if you can help me. So you excluded the same amount of small intestine in both groups. However, do you think the BP limb patients had more weight loss because they had more bile acid absorption, which you have not measured? However, or is it because in the longer BP limb, you are now anastomosing distal ileum or distal jejunum bowel or proximal ileum compared to the shorter one? What are your thoughts?
If I understand you right, your question is it a hindgut effect through food or through bile? Is that
That is correct. That is correct.
Yeah. It's a good question. To be honest, I'm not entirely sure, but I can also, I'm not a bile acid expert, but you let me say it in this way. Maybe you have seen the very nice lecture in December last month on the AIS channel by Carlo Roux. And he showed us a number of animal trials, and one of which was a canine trial where they were able to put a gastrostomy catheter in the stomach, and they blocked the bile stream to the intestine, and they could separately either add or subtract bile or food into the small intestine. And what you saw was, and after that they measured PYY in plasma. Now, when they added bile, then you saw PYY go up. If they added food, PYY went up as well. But if they added both, then PYY was highest. So there is a sort of a synergistic effect of both. So you need both bile and food somewhere in your small intestine to have the greatest effect. Now, another trial they did is on mice where they moved the papillofater more distally in the small intestine, not changing the total length of small intestine. But just by doing that, they could see that GLP-1 went up just by giving bile more distally in the small intestine. So, referring back to your question, you probably need both. So you have to give both food and bile more distally in small intestine to have a marked hindgut and weight loss effect. So it's probably both.
Okay, so I'm gonna go to the questions. I still have some questions, but we have some questions from the audience, so let's go to those first. So first one was a comment, a great presentation, and they asked, was there any technical difficulty with the long BP limb? I've noticed that some of the patients, you had to do a short BP limb because of tethered mesentery. Can you give us more details about this?
Yeah, that's a very good question. Actually, there was. According to the surgeon, I must say that it was in the hands of one surgeon that encountered sometimes a problem with a short mesentery. And if you start measuring a longer BP limb, that could in some cases be a problem in lifting your small intestine up to the level of your pouch. Later on, we maybe because we gained some experience that didn't occur anymore, but it can be, especially in fat males with a lot of internal adipose tissue, then that could be a problem. You could easily cope with that by making your pouch a little bit longer, and you probably won't have that problem anymore. A longer pouch is, for more reasons, probably a good solution, as we know from single anastomosis gastric bypass, for example. So,
but does the longer pouch, sorry to interrupt, does the longer pouch expose you to marginal ulcers, and is another strategy to go retrocolic? Have you ever done retrocolic bypass?
We know about marginal ulcers, especially from the rising numbers of mini gastric bypass that we're doing now. But in a Roux-en-Y concept, that remains to be seen if there is the same problem. What we have proven in earlier studies, and what we're going to publish on next year, is that you, in a longer pouch, you have a slower gastric emptying, which probably will help your weight loss, and also prevent some complaints of dumping. So there's something to be said for a longer pouch.
So do we actually want more gastric emptying or less gastric emptying? I thought the more the pouch empties, the faster it stimulates ghrelin, and then the better it is. So do we want a slower or faster gastric?
To be honest, that's exactly what I thought in the past, but from our recent studies, it shows that it's probably better to have a slower gastric emptying, because the time that your gut hormones remain elevated is longer then, and you probably have a better weight loss effect. So we did a separate study into gastric emptying, looking at gastric emptying times in very good performance in terms of weight loss against a group of bad performance in terms of weight loss. And you saw that in the good performance, gastric emptying is much slower. So what you probably are looking for is a slower mechanism of gastric emptying, which you get from two things: maybe making the pouch longer, or adding some banded kind of concept. And we're looking into both in two separate randomized controlled trials, the results of which we hope to present in Madrid this fall.
Now, this is contrary to a retrospective study that I've seen last year from Brazil, where they took patients, about 67 patients, 3 years after Roux-en-Y gastric bypass, and did CT volumetry and scintigraphy. And they found that if the pouch was less than 40 milliliters and had the fastest emptying in 1 hour, it had the best weight loss, the least weight regain, and no difference in dumping. So this is completely contrary to what you're saying.
I agree. It is completely contrary. Well, I don't have the answer yet, but it just illustrates that we know hardly anything about pouch dynamics, right? And there's not gone a lot of thought into how that pouch actually works. There's been a trend from 50 years ago, a horizontal pouch, towards a vertical pouch, and then to very, very small pouches measuring only 1 or 2 centimeters. But what's actually happening there is very much unknown. Now we see that weight loss results in mini gastric bypass and single anastomosis gastric bypass are usually very good, and you can attribute that to the longer BP limb concept that a mini gastric bypass has, but it also has a longer pouch. So who says that it's only the limb length, or maybe it's the sleeve-like pouch that they're building to prevent reflux? That's also adding to weight loss. I couldn't for sure tell you, but it's a very interesting topic that needs to be studied more.
Sure. Thank you. There's a question from Anna Kamilka, and I'm going to tag on also a part that I also wanted to ask about the same idea. So her question is about the limb length. Why did you choose these particular limb lengths, and did you consider having a constant Roux limb, like either 75 or 150, Also, have you looked into the common channel length in your study? And she's just curious, why did you not measure the total protein and serum albumin levels post-op and compare between both patients? I think it's really an excellent question. And lastly, did you increase the protein supplementation for the longer BP limb?
I'm not sure if I can remember all the questions because there were 4 or 5.
I can remind you, no problem. I'll remind you.
The first question is, why did we choose this particular limb length? That was, well, we were sure that we wanted to compare 2 groups with similar excluded limb length. So that's question 1. And our standard gastric bypass at the time was a Roux of 150 and a BP limb of 75. Obviously, the differences would have been larger if you had chosen a shorter BP limb length, and maybe in the other group a shorter elementary limb length. But we didn't want to disadvantage our control group, so to speak, compared to the standard procedure that we do. And also, our ethical committee wouldn't allow us to go back to a very short BP limb for example, 30 or 40 centimeters. So that's the reason that we started with the standard procedure we're doing at the time, and then adapted the longer BP limb to that length. So your second question was, did we measure common length of the common channel? We did. It was in the original protocol, and we started doing that. But I must admit that our surgeons got sort of bored with that. So after halfway the trial, they found it too time-consuming and too tedious work. So we reached up to about 46% of our patients were measured for their common channel limb length, and it turned out that on average it was about 4.5 meters. It's in the article, you can read about it. No patient reached in any time a common channel lower than shorter than 2 meters. But if you would progress on the idea of increasing BP limb length, then obviously you would reach some point in time where you would start creating a shorter common channel. So that's something you have to keep in mind if you want to still expand on the idea of making your BP limb longer. I'm not sure again about the other questions, but could you help me there?
So, yeah, sure. So before I tell you the other questions, I just want to clarify something. So Roberto Tacchino did a study where he measured the small bowel in Italy, and he found that 10% of patients, both males and females, have a total bowel length of less than 4 meters. Yet in your entire trial, there was no one with small bowel less than 425. How do you explain that?
I don't know. Maybe we just got lucky, or we didn't write it down accurately. Okay. I have no explanation for you. If you want to make sure, in all cases, by all means, just check and do a total limb length measurement before you do any bypass procedure. That's obviously the safest way to go about. But you know, in the Netherlands, I think all bariatric clinics are very keen on fast track. A normal clinic in the Netherlands does about 6 or 7 procedures a day, and there's a lot of focus on enhanced surgery and speed. A typical Dutch surgeon does a gastric bypass in maybe 35 or 40 minutes. And I know that that doesn't always add to quality and outcomes. So it's probably wise to take a little bit longer and then maybe measure your the total length of your bowel. I must, on the other hand, I know about the reports where a regular bypass was done and still they found on secondary surgery an exceptionally short common channel, and apparently that was then one of those exceptional patients that had a very small short small intestine. I've personally never encountered one of those, having done more than 3,000 or 4,000 of these procedures. But I believe it exists.
Sure. So I'm going to just tell you the results of the second poll, and then we'll put up the third poll after that. So the second poll, when do you perform Roux-en-Y gastric bypass? 67% said that they would perform it mostly for reflux, 29% for type 2 diabetes, 0% said never, and 5% for weight regain after sleep, and 95% of the people have voted. So thanks for everyone for voting. So let's put the third poll, and then we'll answer the rest of the questions. So the third poll is, I'm going to also read the poll for you. It says, sorry. Okay, so the third poll says, if you perform Roux-en-Y gastric bypass, how long do you usually make your BP limb? A, 30 centimeters, B, 50 centimeters, C, 75 centimeters, and D, 150 centimeters or longer. So while they answered the poll, I want to tell you the two questions that Anna had. One of them was, why didn't you measure albumin level in patients, and did you give supplements to the longer BP limb different than the shorter BP limb?
Okay, now why did we measure albumin levels? I don't know. We don't usually do that unless there's symptoms of hypoalbuminia. I wouldn't expect in this trial, because excluded small intestine was roughly the same, that you would have any reason to think of hypoalbuminia. So no, we didn't especially do that. We don't routinely do that. As for the other question, we give all our patients exactly the same regimen in vitamins. So there was no
let me tell you why I think she asked her question. So let's say, yes, theoretically, what you left behind in everybody was 200 centimeters in everyone, because you excluded the same amount. Okay, so in the patients with a shorter Roux limb versus the longer Roux limb, we know that a person could absorb protein and carbohydrate in the Roux limb.
Yeah.
So the one with the longer Roux limb has a total alimentary limb that is 75 centimeters longer, and potentially has a lower incidence of protein calorie malnutrition, just theoretically.
Yeah, I get that. That's right. That's right. I get it. But it's yeah, well, as you've seen, our shortest of our Roux limb in the short group was 75 centimeter, added to the 2 meters that we had at least in common channel. But we also that's probably enough. 2 meters 75 is probably enough to prevent any hypoalbuminemia. Difficult word. But it could be a point, especially when you would be looking into limb lengths where you even enlarge the length of your BP limb and make your Roux limb even shorter, then you could get into trouble. I agree with that. Yes.
Sure. So we have a question from Dr. So we can take down the poll down. So Manuela, thank you. So we have a question from Dr. Iyad Wahabi from New York. He asked, do you have any patients with post-op reflux?
And not to speak of, no, because that's what a gastric bypass and Roux-en-Y concept basically does, right? So there is that you can measure reflux even in Roux-en-Y patients, but it's uncomparable to any of the other procedures. So not really, no. Right.
So there's another question from Dr. Adriana Rotondo. And she asks, first she tells you, congratulates you on the trial. And then she asks if you revised any sleeve to Roux-en-Y for weight regain or reflux, which length would you do the BP limb?
Again, please, if you revise sleeve?
Yeah, for reoperative surgery, what length BP limb do you use?
Thanks for the question. Nice that you tuned in, Adriana. Good question. We use exactly the same. As you can see in the 2 trials, the other one is in EPUB already in sort, but it has to be published on paper still. But we choose this concept. So a BP limb of 150, also in reoperative surgery. But you could consider going a little bit longer if you're doing it for for weight regain. But to be quite honest, we hardly ever do a gastric bypass to treat weight regain after a failed sleeve. In those cases, we would go for any kind of malabsorptive procedure, such as a SADI or a duodenal switch, because I'm not a strong believer in gastric bypass surgery to make up for the failures of a sleeve.
Okay. So Dr. Iyad Wahabi from New York has another question. Do you vary the BP limb with BMI? So like to tag to his question, if you have a super obese patient, BMI 50, 55, 60, and you chose to do a Roux-en-Y, I know you could choose to do a DS, I get it. But if you chose to do a Roux-en-Y, what length BP limb would you do?
Again, we're very simple folks, so we always do the same thing. And because we're with 4 surgeons doing this type of surgery, and there's no, and we have a very dedicated operation team doing exactly the same thing. If one surgeon wants to change anything in the procedure, then the other 3 have to concur. Otherwise, it's not comparable anymore, and the team gets mixed up and confused. So no, it would be again 150 BP limb, even if BMI would be super obese, over 55 or over 60. Although in such cases, as a primary case, we would probably choose a sleeve and then do some other kind of secondary procedure afterwards, probably a SADI. So in cases over 55 or 60, in our clinic, probably a sleeve is the first choice.
So I have a couple of questions. One of them is, you had internal hernias despite closing the defects. So my first question is, how do you close your defects? And did you encounter any patients with obstruction at the JJ, like the Swedish trial, when you closed the defects?
Yeah, we do have that. You know, as you have noted, I'm a big fan of gastric bypass surgery. But you're right, the internal defects and the internal hernias is one of the biggest drawbacks of gastric bypass surgery, of the Roux-en-Y concept. We close with hernia staples, which is a very Nordic technique and which is very fast, but it's not necessarily the absolute best you can do. If you want to make sure that it's closed and it stays closed, then you should probably suture it. I think we're well beyond the era where important guys in bariatric surgery land shouted out loud to audiences that you didn't have to close them. You do have to close them, and the Swedish has made it very clear that you do have to close them. In some cases, you're bound to have some small bowel obstruction. We don't see that very often, and you can prevent it by leaving the last centimeter or so, last few centimeters up to your intestine open. There's a very small chance that it herniates there, and you prevent the small bowel obstructions. If you have an internal hernia rate of around 1%, you're doing a very good job, I think, and that's very acceptable.
Great. And the second question is about gallstones and cholecystectomy. Did you give your patients ursodeoxycholic acid?
We're not used to do that in the Netherlands. You could build a case to do it anyway. It's as you know, it tastes very bad. A lot of patients, you give it, but they will not take it. But if you're interested in doing less cholecystectomies, you could go in that way. We don't have a protocol in place to do that now. Okay.
So I'll say the results of the third poll, and then we'll do the fourth poll. So the third poll, most people chose 75 centimeters, 50%. 30% chose 150 or longer. 15% chose 50 centimeters, and 5% only chose 30 centimeters. That's actually interesting to me. I mean, I would not have guessed that a third will do 150 or longer. So it seems like you're convincing people, Fritz, to change. Yeah. So Manuel, let's put out the last poll. Okay. So the last poll, we'll wait for it to come in a second right here. So do you feel a longer biliopancreatic limb improves weight loss outcomes? Yes, no, too early to tell. So while people are taking the poll, and I want to thank everyone for taking the poll, I really appreciate their participation. I have two questions for you about complications. Well, first of all, I have to commend you for having a randomized controlled trial with a very low complication rate. But it caught my eye,
Thanks.
and you mentioned maybe a type 2 error about the mortalities. But it caught my eye that the mortalities are related to VTE or their treatment, possibly. So one was a mortality that potentially is a VTE, like a PE, and the other one was from the bleeding. And you used Fundoperinox 5700 once a day for 4 weeks. So my question is, Fundoperinox has been shown to have higher bleeding rates than low molecular weight heparin. So did you give a dose pre-op? That's the first question. Second question is, you give everybody 4 weeks. So you were bound to have patients who are lower risk with lower BMI. The patient who had bleeding, what was their BMI? And the patient who had VTE, what was their BMI? Because most people now recommend that you actually give extended prophylaxis, but you choose which patients to give it to and to give higher doses for certain patients based on the Annals of Study Surgery published by Ali Aminian in 2016. So we can take the poll down. Thank you.
Yeah, it's a good question. You know, nowadays our most important serious adversity trend in the first postoperative period is bleeding, which is a reason that already in this trial we gave our heparin starting 2 hours after surgery, not before surgery. Still, nowadays around 2%, we have around 2% serious bleeds, of which most can be treated conservatively, but some you have to reoperate on. Now it's striking that the other patient died from probably an embolic event, but we cannot be entirely sure because we were not allowed to do a post-mortem study on her. But in her house were found a lot of syringes that she should have used in administering heparin. Now, if you have a choice between, on the one hand, the bleeding complication, on the other hand, your embolic events, these embolic events are so rare that you would probably go for maybe giving less prophylaxis to your patients in your perioperative period. It's not so that we necessarily give all our patients the same prophylaxis, because we did a study on this published last summer in Obesity Surgery showing that in heavier patients there's an inverse correlation between lean body weight and anti-10A activity. So what we do is in patients heavier than 140 kilograms, we give them double dose. But it's always unsure how your bleeding rate is related to the amount of heparin, and the timing of the heparin that you give is for sure just as important than how the quality of your surgery is. And I'm a bit worried that the haste that we sometimes have in our fast track protocols, striving to do a procedure every hour, finishing before 3 o'clock and having done 7 procedures in a day, tended to make us look a little bit less careful at bleeding sites. So if you would take in every procedure maybe 10 minutes extra, then I think in spite of your heparin protocols, you would probably have better outcomes.
I don't think any place in the world you could do 7 procedures and finish before 3. Maybe
you,
only
you
in the
should come and visit. I come.
I know it happens. I've heard about it. So just the 2 patients, the VTE, what was the BMI of the patient, and the bleeding patient, what was the BMI of the patient?
To be honest, I'm not sure anymore. I don't know.
Great. I want to first say the poll results. So 61% said yes, the BPLM has a role. 28% too early to tell, and 11% no. So you still have 11% that you have not convinced. So I'm going to give you maybe a chance to address everyone and give us any final parting comments. I really enjoyed this hour with you. It's very clear that your group is a very scientifically minded group, and you have contributed significantly to the literature. So we thank you for that. We congratulate you on this trial as well as on the other trial that's on in sort. Thank you for letting us know. I will look at it. I have not seen it, and we look forward to your presentations in Madrid about the banded and the long pouch gastric bypass. So please give us any parting comments, Fred.
Well, I must say I'm amazed to see in these polls that already a lot of people are into longer limbs, and although there's still a group that has to be convinced, let me invite them to just look for themselves how they find their own way. More important than what you hear others say about how your gastric bypass or other surgery works, it's always very important to me that you look critically at your own work. It's strange, isn't it, that a gastric bypass design originally thought out by Mason and later adapted by Griffin in the 70s stays the same for 70 years. Why is that? Did they get it right the first time, or are we not critical as surgeons to come up with something better or something improved? And compared to a sleeve, for example, where we know exactly what the distance to the pylorus should be, the distance to your LAS, the diameter of your sleeve, strangely enough, this gastric bypass, which is a very solid and good operation that goes along goes for such a long time and works so well, has deserved so little of our attention. So that's my comment to you. Don't take my word for it. Just look for yourself. Do a small pilot or anything. Compare some long limbs with short limbs, longer pouches, shorter pouches. See what works good for you, and but be critical about it.
Thank you, Fritz, very much for your time and for your comments. I want to thank everyone for joining our webinar today. And our next journal club will be next month. I want to also invite everyone February 7th to our next monthly webinar, which is going to be with Professor Scott Chikora from Harvard, discussing how to publish your research. I don't think Fritz needs to attend that presentation. Well, again, thanks everyone, and have a nice day. Bye-bye. Thank you, Manuela, for organizing it. Okay, thanks, Fritz. Bye-bye.
Bye-bye.